Hey guys, welcome back to the ABG Part 3 video series. In the previous two series of videos, we have seen what is an acid, what is the base, how we have to take an ABG sample, where are all the sites we can take the ABG sample, and how the ABG analyzer works. In video Part 2, we have seen how the compensatory mechanisms acts in order to maintain a pH in normal range of 7.35 to 7.45. In this video, we are going to see exclusively about how to read an ABG report. After getting the analysis report from the ABG analyzer, how we have to read it and how we are going to interrupt. Before going into the topic, we have to know about certain terms like what is acidosis, alkalosis, alkemia, alkalemia, what is the primary disorder, what is the secondary compensatory mechanism, what is the simple acid-base disorder, what are the complex or mixed acid-base disorders. So what is acid? Acid is nothing but the molecule which donates proton is called an acid. So whenever there is H plus concentration that is high in the blood, it is known as acidemia. Whenever the H plus concentration is less in the blood, then we call that condition as alkalemia. So then what about acidosis and alkalosis? The conditions, the basic pathological condition that are contributing to increase in H plus concentration in blood is called acidosis. The same pathological condition which causes decrease in H plus concentration in blood is known as alkalosis. So primary disorder is that the primary basic pathological condition that causing the acidosis that will be called as primary disorder. The compensating mechanism, say that it is the buffer or renal or the pulmonary, which is trying to compensate for the primary disorder induced acidosis or alkalosis, is called the secondary disorder. Simple acid base disorder is nothing but the ABG disorder will be having only one primary disorder, or if the ABG is having more than one primary disorder, then we call it as a mixed acid base disorder. Then we have to know about an important term which is known as the anion gap. Anion gap is nothing but the difference between the number of cations and number of anions in plasma. All the ions can be measured at simultaneous time. So some ions are measured, some of them are unmeasured. So ions like sodium, potassium, chloride and bicarbonate we can usually measure with the help of the blood sample. So by using the calorimetry or flow photometry or ion specific electrodes, we can determine the anion gap. The formula for determining anion gap is sodium minus chloride and bicarbonate. Normal value is 10 plus or minus 4. But if you measure using the ion specific electrodes for measuring the electrodes in ABG, then the anion gap ranges from 3 to 11. It is nothing but to quantify the metabolic acidosis into high anion gapic metabolic acidosis or non-null anion gap metabolic acidosis or low anion gap metabolic acidosis. So then what are the unmeasured anions? The unmeasured anions are nothing but potassium, calcium, magnesium, sulfate, phosphate, albumin, and other plasma proteins and organic acids. These are all unmeasured anions. Before going into reading the ABG report, there are 5 basic steps in analyzing an ABG. The first step is we have to check the validity of the ABG. If the ABG is invalid, then there is no point in further continuing or further analyzing or interpreting the ABG. So what is that formula of checking the validity of ABG? It is nothing but by using the Henderson-Hasselbalch equation, H plus concentration is equal to 24 into carbon dioxide by bicarbonate. So this we take it as A plus. The carbon dioxide and bicarbonate level will be given in the ABG report. The second calculation is H plus concentration is equal to 80 minus 2 digits of the last 2 digits of pH. Or we can formulate by using the formula H plus for every 0.1 decrease in pH, we have to multiply H plus concentration by 1.25. For every 0.1 increase, we have to multiply it by 0.8. So A must be equal to B, then we have to consider it as invalid. So after checking the validity, we are going to assess the oxidation status of the ABG. So for normal PO2, P is 100 millimeter of mercury at a room air of 21%. So then we are measuring the PF ratio by using the PO2 and FiO2 which are delivered. If it normal ranges from 400 to 500 millimeter of mercury, if the PF ratio is less than 300, then we call it the term as ARDS, which is nothing but acute respiratory distress syndrome. For mild, it is further categorized into mild, moderate and severe ARDS. So severe ARDS is nothing but less than 100 of a PF ratio with bilateral chest infiltrates and PEEP of 5%, PEEP of 5 in ventilatory support. So moderate is 100 to 200, mild is 200 to 300 with bilateral chest infiltrates with PEEP of 5 after 1 week of the pathological injury causing the ARDS. Normal PO2 vary according to the age. For elderly, it won't be same as that the young fit adult in 20 years of age. So PO2 according to age is 100 minus age by 3. If PO2 is not normal, then PO2 and PCO2 varying but with normal pH, then we call it as respiratory failure. So in type 1 respiratory failure, PO2 will be low and PCO2 will be normal, pH will also, there won't be any change. Then we call it as type 1 respiratory failure. In type 2 respiratory failure, there will be increase in PCO2 and decrease in PO2 with no change in pH. The reason for hypoxia has to be determined. So if the oxygenation is improving with the supplementation of oxygen, then we call it as VQ mismatch. If it doesn't increases with the help of oxygen supplementation, then we call it as a shunt. So the another part in assessing the oxygenation is alveolar arterial pressure gradient of oxygen. So alveolar arterial pressure gradient is nothing but the difference in oxygen concentration in alveoli and artery. So how we can determine the alveolar oxygen content, which is nothing using the gas law, which is PaO2, that is the alveolar concentration of oxygen is equal to FiO2 into barometric pressure minus water vapor pressure minus PCO2 by respiratory quotient. The PCO2 we can get it from the ABG. FiO2 we can measure if it's room air, it's 0.1, or we will be supplying oxygen at certain particular FiO2. The respiratory quotient is 0.8. By assessing this, we can measure the AA gradient. The normal is 5 to 10 millimeter of mercury. The next step in assessing the ABG is the hydration status and acid-base disorders depending upon the sodium and chloride reactions. Normally, the sodium is around 140 milliequivalents per liter and chloride is around 100 milliequivalents per liter. It is useful when ABG analyzing is impossible. Then we can, with the help of sodium and chloride mismatch, we can inconclusively we can say whether the acid-base disorder is present or not. So the normal sodium and chloride ratio is 1.4 for sodium and is 1 for chloride. For in overhydration, there will be a proportionate decrease in concentration of sodium. For example, sodium when it decreases from 140 to 126 and chloride decreases from 100 to 90, that is proportionate 10% decrease. Then we can call it as overhydrated state. For dehydration, the same thing will be happening, but proportionate increase in both the concentration of sodium and chloride. For example, sodium increases from 140 to 156 and the chloride increases from 100 to 110. There is 10% increase in both the concentration. Then we can term this condition as dehydrated state. If the sodium remains normal, but the chloride concentration varies disproportionately in a chloride, for example, if chloride decreases from decreases disproportionate to sodium, then we call that condition as respiratory acidosis or metabolic acidosis. If the chloride level increases, then we call it as hyperchloremic metabolic acidosis or respiratory alkalosis is present. These are the inconclusive terms. These are not definite for the diagnosis of acid-base disorders. Then we can combine whether the overhydration is present or some metabolic disorders are present with the help of the sodium chloride disproportionate increase or decrease in the conditions. If disproportionate decrease in chloride concentration when compared to sodium and the ratio of 1.4:1 is altered, then we call the condition as overhydration associated with metabolic acidosis. When we call the dehydration with metabolic acidosis, if there is disproportionate increase in both sodium and chloride, but more proportionate increase with the sodium concentration, then we call it as dehydration and metabolic acidosis. So after assessing the dehydration status, oxygenation and validity, then only we are going to assess the acid-base disorder. So in the fourth step of assessing the acid-base disorder, we are going to identify acid-base disorder by the traditional method. Before going into the traditional method, the acid-base disorder should be evaluated at the background of proper history taking and clinical examination, which will be playing a vital role in arriving at a diagnosis. So the first step in assessing the acid-base disorder is we have to look at the pH. What is the pH? The normal pH ranges from 7.35 to 7.45. pH is nothing but the negative logarithm of H plus concentration. So if the pH is less than 7.35, if it is associated with decrease in bicarbonate level which is less than 25, then we call that condition as metabolic acidosis. If the pH is less than 7.35, which is associated with increase in carbon dioxide levels of more than 40, then we call that term as respiratory acidosis. But if the pH, even though it is in the normal range of 7.35 to 7.45, there could be some mixed disorders that could be associated with that condition due to the secondary compensatory mechanisms. If the pH is less than 7.35, we commit a diagnosis of metabolic acidosis or respiratory acidosis, as I have mentioned just previously. If the pH is more than 7.35, we will call that condition as alkalosis. If that alkalotic condition is associated with increase in bicarbonate level of more than 25, we call it as metabolic alkalosis. If the 7.45 pH is associated with decrease in carbon dioxide level of less than 40 millimeter of mercury, we call that condition as respiratory alkalosis. By using these simple steps, we can arrive at a conclusion whether the alkalosis or acidosis is present, and if it is alkalosis acidosis, whether the metabolic component or the respiratory component is present, we can identify at this level of evaluation. If acidosis is present due to the respiratory component, then we have to classify whether it is due to the acute component or it's the chronic condition that causing the respiratory acidosis. So how we can determine it? We have to calculate the change in pH. So in acute condition, the pH change should be 0.008 into change in PCO2 level. So if it's a chronic condition, then the change in pH should be 0.003 into change in carbon dioxide level from the normal range of 7.35 to 7.45. We have to compare the derived pH with the measured pH in the ABG. If the pH is close to the component A, which is the acute phase, then we call that respiratory disorder is as an acute condition. If the pH which is measured is close to the derived value of pH in B, then we call that condition as chronic disorder. So by using this simple formula, we can also arrive at a conclusion whether the respiratory disorder is acute or chronic, or it could be an acute and chronic condition. After assessing this, we have to measure for the compensatory mechanisms, whether it is fully compensated or undercompensated. In case of metabolic acidosis, the primary defect is less than 25 milliequivalents of bicarbonate. The compensatory mechanism is decrease in carbon dioxide level with the help of hyperventilation. So we can measure the compensatory mechanism as PCO2 should be 1.5 into bicarbonate level plus 8 with the range of plus or minus 2. In case of metabolic alkalosis, the primary disorder is increase in bicarbonate levels with the compensatory hyperventilation leading to increase in CO2 levels. So the compensated measured PCO2 is equal to 0.7 into bicarbonate concentration plus 21 plus or minus the range of 2. For metabolic acidosis, the compensatory mechanism should be measured, and whether it is undercompensated or correctly compensated, we have to identify, which can be easily identified by PCO2 is equal to last 2 digits of pH. So if the pH is 7.47, then last 2 digits of pH, which is 47, we can compare it with the compensatory mechanisms. In case of respiratory acidosis, the primary defect is increase in CO2 levels with the compensatory increase in bicarbonate, which is the secondary condition. So for acute, we have to buffer with the help of rule of 1. For a 10 millimeter change in CO2 level, the bicarbonate should increase by 1 milliequivalents per liter. For chronic condition, we have to use the rule of 4, which is the generation of newer bicarbonate. For every 10 millimeter mercury of change in PCO2, the bicarbonate level should increase by the level of 4 milliequivalents per liter. In respiratory alkalosis, for acute condition, the buffering rule of 2 should be applied. So in respiratory alkalosis, there is decreased PCO2 level with a decreased bicarbonate level. So in acute condition, for every 10 millimeter mercury of change in CO2 level, we have to decrease the bicarbonate level by 2 milliequivalents per liter as a normal compensatory mechanism. In chronic conditions, that is due to decreased reabsorption of bicarbonate or increased H plus excretion, for every 10 millimeter mercury of change in carbon dioxide should be compensated by decrease in 4 milliequivalents per liter of bicarbonate. So after checking at the compensatory mechanisms, we have to check for some gaps. There are three gaps: anion gap, osmolar gap, and delta gap. As we have previously mentioned, anion gap is nothing but the difference in number of measured as well as the measured cations as well as measured anions. So anion gap formula is sodium minus chloride and bicarbonate. Normal range is 10 plus or minus 4 or 12 plus or minus 2. So when the anion gap is increased, then increased component is mainly contributed by the number of unmeasured anions. In normal anion gap metabolic acidosis, for every bicarbonate loss will usually be accompanied by the cationic loss. But in case of high anion gap metabolic acidosis, the anion gap is mainly due to the increased in blood concentration of the unmeasured anions. Either it could be due to glycol or glycerol or salicylate poisoning or renal tubular acidosis. The unmeasured anion concentration will increase, and which will lead to the high anion gap. So despite the measurement of anion gap, we have to calculate the corrected anion gap to compensate for hypoalbuminemia. So for every 1 gram percent decrease in albumin level below 4 gram percent, we have to add 2 to 3 for corrected anion gap measurement. If the anion gap is normal despite the presence of metabolic acidosis, then we have to assess the urine anion gap, which is nothing but the same anion gap difference in urine. The urine osmolar gap is the urine anion gap is the difference between sodium and potassium and minus chloride. Which is usually will be in normal or negative range of minus 20 to 50. But if the value is slightly positive or more positive, then there are high chances of distal renal tubular acidosis or chronic renal failure is accompanying is the condition that is leading to metabolic acidosis, because there will be loss of bicarbonate and decrease in H plus excretion. So after looking at the anion gap, we can classify the metabolic acidosis into high anion gap, low anion gap, or normal anion gap. If there is normal anion gap, then we will be measuring the urine anion gap to determine whether distal renal tubular acidosis is present or not. The second gap we are going to look is the delta gap. Delta gap is nothing but the difference between delta anion gap and delta bicarbonate. Delta anion gap is nothing but the difference between patient anion gap and the normal range of 12. Whereas the delta bicarbonate is nothing but the difference between normal range of 24 minus the patient's bicarbonate. Difference between these two of delta anion gap and delta bicarbonate will give the value of delta gap. Normally the delta gap is 0. Usually the normal delta gap is 0. But if there is increased or decreased in delta gap, then there is high chance of mixed acid-base disorder to be present. So normally if the delta gap is more than 6 milliequivalents per liter, then there is high chance of metabolic alkalosis associated with metabolic acidosis. If the delta gap is less than 6 milliequivalents, there is high chance of hyperchloremic metabolic acidosis to be accompanying the primary disorder. The third gap which we are going to discuss in detail is about the osmolar gap, which is nothing but the difference between the patient's serum osmolality and the measured osmolality. So difference between two osmolar gaps should be less than 20 milliosmol per kilogram. If the measured osmolar gap is more than 20, then there are high chances of osmolar solutions to be present in the measured serum. So what can be the causes for increased osmolar gap? Like in case of ethanol poisoning or methanol poisoning or isopropyl alcohol poisoning or ethylene glycol poisoning, there are high chances of osmolar glycerols and alcohols to be mixed in the serum sample to cause increase in osmolar gap. The last step in assessing the ABG disorder is we have to find out what is the basic condition or the pathology causing these metabolic disorders, and we have to correlate with the history and clinical examination for final confirmation. As majority of the ABGs we interrupt in a clinical scenario will be of metabolic acidosis. In this video we are going to further study in detail about metabolic acidosis. So what will be the cause of metabolic acidosis? As we have seen in the previous sessions, metabolic acidosis can be due to high anion gap, normal anion gap, or decreased anion gap. What is the cause of high anion gap, which is anion gap of more than 14 which is glycol, like ethylene glycol or propylene glycol poisoning, or L-lactate or D-lactate accumulation, methanol poisoning, aspirin, renal failure, diabetic ketoacidosis, drugs like salicylates, paraldehyde, isoniazid, and iron. These are the conditions that can cause high anion gap metabolic acidosis. What will be the causes for normal anion gap metabolic acidosis? Normal anion gap metabolic acidosis is further evaluated with the help of urine osmolar gap. The conditions like diarrhea, ileal conduit, uretrosigmoidoscopy, carbonic anhydrase inhibitor usage, and conditions like distal renal tubular acidosis of type 1, 2, 3, 4, and CKG stage 4 and 5 can cause normal anion gap metabolic acidosis. And dilutional acidosis and recovery phase of diabetic ketoacidosis, there will be normal anion gap. What are the causes for decreased anion gap metabolic acidosis? Like albumin, change in albumin concentration like hypoalbuminemia, IG myelopathy, salicylate poisoning. These are some of the conditions which will be associated with decreased anion gap metabolic acidosis. Conditions like hypercalcemia, hypermagnesemia will also contribute for decrease in anion gapic metabolic acidosis. Lithium toxicity is also another condition which is associated with decreased anion gap, even though it is associated with metabolic acidosis. So by looking at the anion gap, and you can classify metabolic acidosis into three, like high anion gap, normal anion gap, and decreased anion gap metabolic acidosis. If that is normal anion gap, then we can further trim down by using the urine anion gap to find out the real cause. So despite the presence of these much of acids in the blood, there will be some clinical manifestations which is due to metabolic acidosis. Like in cardiovascular system, the heart rate and cardiac contractility will be initially compensating with increase in heart rate and cardiac contractility up to pH of 7.2. If the pH is decreased beyond 7.2, like 7.1 or less than 7.1, there will be decrease in contractility of the myocardium, decrease in response to catecholamines, decrease in renal as well as hepatic blood flow, decrease in fibrate threshold, leading to increased chance of atrial fibrillation and other arrhythmias, and increased in peripheral vasodilation and decreased in blood pressure, which is leading to further worsening of the shock, which will lead to increased lactate production, and lactate production will further cause acidosis, and this will be in a cycle. In case of cerebral manifestation, there is increased sympathetic stimulation, altered mental status, decreased cerebral blood flow, and decreased cerebral metabolism of the metabolites will be happening. In case of pulmonary system, to compensate for the increase in acids, there will be hyperventilation, like increased minute ventilation, which will leading to dyspnea. Due to hyperventilation, there will be decreased in diaphragmatic contractility. The other features which are occurring due to acid production is decreased in anaerobic metabolism, increased protein catabolism, and the phagocytes functions will be diminished or altered, decreased in ATP production, and decreased in bone or skeletal growth, which will lead to bone pain due to the buffering mechanisms of bone associated in compensating for acid increase. So these are the traditional approach by which we can determine whether the acidosis or alkalosis, what are the causes of acidosis, like metabolic or respiratory, and we can find out the basic pathological condition which is leading to the acid-base disorder. Apart from this traditional approach, there are certain approach like Stewart approach with the use of strong ion difference, and semi-quantitative approach we can measure the acid-base disorder. Why that these approaches are discovered is mainly due to the defect in traditional approach. Bicarbonate and metabolic component is not quantified in a traditional approach, but it is indirectly calculated. But it also has the defect of it does not consider the contribution of weak acids. Despite these two negative bias of traditional approach, there is also another important relationship defect between the acidosis and bicarbonate level measurement, which is not only inconsistent but also not linear. So due to these effects, Stewart approach and semi-quantitative approach can be applied for measurement of acid-base disorder. Explaining this is beyond the scope of this video. If anybody wants, let me know in the comment section. So until then, it's Uday signing off. Take care.